And we do have a question to start with. So I will start with Dr. Murray. What are your thoughts in using different sutures besides ethibond and vicryl? Obviously, a lot of research has gone into those types, but what are your thoughts in substituting with other suture types?
Yeah, so I think I mentioned it a little bit. I think I'd be careful with some of you just need to know what you're putting in the knee and what the reaction of the material is likely to be in the knee. So some sutures have been found to cause granulomatous reactions or other reactions in the joint. So you just want to be a little bit careful with that. But then I'd say if you're going to change from the technique that was studied in Bear 2, probably the most important thing is to study your results. And so that if there is a problem, you know about it sooner, but also if something's better, you know about that as well. So I think that's really the key. If people are going to change from what was done and reported on in Bear 2, just study the results so that everybody can benefit from if you find something that works better.
Great, thank you. The next question for Dr. Osbahr. So why is the rehab protocol slightly different in the first 4 to 6 weeks for bears compared to a reconstruction?
So first, I just want to point out the humility of what was just said. Often when people come up with a technique and invent something, they want to own it and keep people doing it the way they envisioned it. And so very appreciative of the idea that innovation and advancement should always be in our wheelhouse. And I think Dr. Murray's perspective to that. And so part of it, it's interesting. I talked about my journey into where I went, and I used to do ACL repair and really focus on how quickly a patient could get back and how the fact that they felt like it was a knee scope. And as I kind of went through this restoration kind of analysis in my head about why doing it, I really learned a lot about myself about faster isn't always better. And what are we really trying to do early on? If we move somebody too quickly, we're not really giving the body the ability to enhance what we're trying to do, which is healing at that environment. So often slowing down that process initially gives us the ability in the body to heal that site to then make progress further. And so for me, whether I would do a primary repair or a restoration technique, I think it is important to allow the body to heal, to slow down initially. And that's kind of the journey I've been on since then. And so really from a PT perspective, obviously that has changed over time to partial weight bearing, 0 to 45 degrees in the first 2 weeks, 45 in the next 2 weeks, and then really you're off to the races. I do tell all the physical therapists I work with, just because you're going slower initially and the patient could go quicker, so be careful about that. You still can work on patellofemoral mobility, making sure you're limiting adhesions to the front of the knee, making sure the patient out of the brace is truly getting full extension, because as we all know, the patient in the brace doesn't necessarily truly have full extension, and they do bend the knee a little bit. So I think there's a lot of things to work on, and especially getting the patient comfortable with proprioceptive feel of having people lay hands on them. And so I've had situations where a lot of PTs looked at it like, well, there's nothing I can do now, so there's no reason to come in. And what I've had them focus on is just really working on those things. It's just different than a typical reconstruction where people mentally know I gotta win this race, otherwise they're going to get stiff.
Great, thank you. Next question for Dr. Murray. Based on histology and biomechanical testing in preclinical models, what gives you confidence that bear will bridge a gap that resembles an uninjured ACL?
Well, histologically, and we carried the pig studies out to 6 months and a year, and the histology of the ACL continues to improve, just like it does for the MCL. So if you look at the MCL in animal models, it doesn't look totally normal even at a year. So we really do feel like it's heading in the right direction. But of course, those are animal models, and that's the best that we have for histology. And what was the second part of the question for biomechanics?
Yeah, so what gives you the confidence that bear will heal amid substance and just like an uninjured ACL?
Yeah, well, we've seen it now in over 400 pig surgeries, so it's worked the vast majority of the time. I'd say maybe we have a 2 or 3% of the time, for some reason, the pig doesn't heal the ACL, and that's probably going to be true in people as well. But we don't know that. So I think all we can do is really just study it and look at and report on all of our patients and look and see, does it work? I think right now in Bear 2, we saw all of them heal on MR. So in Bear 1, the same way. So that's the first 75. So all of you who are doing this procedure now, hopefully you're getting MRs and looking at them and feeling their knees and feeling that they're stable, and we can just continue to accumulate the clinical evidence.
Great. Another question for Dr. Murray. How far out can we safely wait after the initial injury to perform a bear?
Yeah, that's a good question. We only waited, I think, 50 days or so in Bear 2, because we had done studies in pigs where we delayed the procedure. So we would cut the ACL and then go back and fix it 6 weeks later. And the results were not as good as if you did a repair right away. When we look at the time from injury within that 50-day window, if we look at the time from injury and then the predicted strength of the bear repair based on their MR results, we don't see a very linear line, meaning that it's kind of like a snowstorm on the graph. So we think between 0 and 50 days, there's not much influence of the time from injury, but we don't know how far out we can push it. I think we've all seen patients who at 6 months, somehow the ACL has stuck to the PCL or something, and it's still got a nice big piece of tissue there. And maybe those would be okay longer out, but I just, there's no way I could comment on it because we didn't look at those.
Okay. For Dr. Osbahr, for elite teenage athletes, basketball, volleyball, etc., is it recommended that the patient wear a functional brace as they return to sport? Is there any advantage with a functional brace?
So I think this question to me is more agnostic of restoration versus ACL reconstruction itself. To me, a brace has always been a more conversation point about the psyche of the patient. What I always focus on with my patients psychologically is the fact that I want them to be able to play sports symmetrically. The fact is there's no evidence that an ACL functional brace protects them from re-tearing an ACL. And my feeling is, there's two ways to think about it. Some patients might feel protected in the brace and have more suboptimal movement patterns, or they offload that knee that's in a brace and then put more pressure on the other knee. And so what I focus on with my patients is symmetric movement patterns. And if the brace enables them confidently and psychologically to be able to play more symmetrically, then I think that that's important. But again, there's no evidence that it will protect them and prevent an ACL injury. The other thing I would say is it's sport specific. So I treat a lot of soccer players, and it's difficult to wear a brace in soccer. And so, there's going to be sport specific considerations and position specific considerations that I think need to be taken into account. But that's a conversation I typically have with people around anywhere between around the 5-month mark in their recovery, where we start to go down that road about how they're going to feel.
Okay. Another question for Dr. Osbahr. Is there a concern about higher failure rates in younger active population, and how can we improve this?
Oh, absolutely. There's a concern I have a higher failure rates in younger population and elite athletes, no matter what procedure I do, whether it's restoration or ACL reconstruction. And actually, if you look at the Moon calculator and information and take that and normalize the studies, I know we always quote reconstruction has a 5 to 10% re-tear rate, but once you start increasing the elite athlete status, soccer player, female, start going down that road, re-tear rates can be upwards of 15 to 20%, even in reconstructions. And so I think it's important to understand that there's high risk patients. And for me, what I walk into the room now is more of telling a journey and talking to the patient about that we're a multitude of options. And in elite athletes, to me, more it's perception at this point, more than anything else. When you take care of a team or a professional team and you have athletic trainers and you have, agents and things such as that, there's a multitude of people giving advice. And sometimes that affects judgment and perception and the procedure they want. What I think we're on a journey, and I think Dr. Murray helped start a journey with others about finding more options to treat patients and lower complication rates. And we might find out in 10 years that why weren't we doing this on more patients? But certainly, what keeps me at night is my young patients and elite athletes, and especially soccer players that tear their ACL, no matter what procedure I do on them. So I think that's an important concept for everybody to have, and this has definitely played a positive role in me in all ages of patients. But you got to find the right option that the patient resonates with.
Great. Another question, a lot of rehab questions. So this one for Dr. Osbahr. From a surgeon rehab specialist perspective, how does the quadricep recover? We see a lot of inhibition that prevents effective strengthening. Post-op reconstruction is Bear different. Does the slower rehab in Bear slow the quad recovery down?
I think the slower rehab slows the quad down, but not as much as reconstruction. The quad is always a difficult thing to build in a post ACL world. Our best quality therapists are really amazing with how they can build a quad in difficult situations. And one of the things I see is when people layer quad inhibition and then start to do too much with the athlete, they definitely take a huge step back, more prone to anterior knee pain. So I think it's a problem in all of our patients. What I've noticed when I have done either repair or now restoration, the quad does tend to be less inhibited and less of an issue in terms of restoring. But again, I think it continues to be a problem no matter what knee procedure we do. Unless patients are weight bearing as tolerated, you rush them out of the gate from a knee scope perspective and they don't have limitations. Those are the only times that the quad tends to function quicker and get back quicker.
Okay. Another PT question for Dr. Osbahr. I'm a PT and my son had Bear on October 2022. Any thoughts on the initial stiffness, difficulty aligning with initial goal of range of motion immediately post-op? Protocol said never to push range of motion, so it was a bit of a loss. Swelling was controlled well, but still stiff, and prehension was not an issue.
Well, geez, I definitely don't want to say they had a bit bad physical therapist, huh? Well, it's interesting. I treat a lot of physical therapist family members, and I always suggest number one, they don't do the physical therapy, just because it's always hard to balance that, obviously with family members. But it is, some patients do tend to have a little bit more stiffness. I find it not to be the arthrofibrosis stiffness. But that's where I think initially really got to focus on patellofemoral mobility, patella tendon mobility, really avoiding getting Baja. And as you wait through those first several weeks, and then I have found that patients that really have work with physical therapists, as I had mentioned earlier in the presentation, that have a solid ACL experience, tend to be able to work through those things with time. And honestly, in the 60 patients I've done, I've only had that one person I've reoperated on. I know earlier in some of the Bear trials, the range of motion was slower. And so there were some other patients that were getting a little bit stiffer initially than that. But again, I think the resounding feeling of a lot of people that do this technique feel like it's not the same arthrofibrosis that we see after reconstruction in those patients that do get stiff. Now, for me, I have been a little bit more patient in terms of allowing people to get their range of motion. So as you could tell with a case I presented, I waited 5 months. But honestly, for me, once you start getting to that point, there's diminishing returns, and I'd rather take a patient to the operating room and confirm that I'm able to get rid of any adhesions and do that process under anesthesia, because otherwise all the things that I talked about in the last patient about quad inhibition start getting larger and larger, and the patient starts having a longer return back to normal recovery.
Okay. Another question for Dr. Osbahr. You said you've done around 60 Bears at this point. What was your learning curve like?
Wow, I'm still learning. I think so. Putting it this way, I probably have done in terms of repairs over the years and restorations over the last 10 years or so. Probably 100 repairs before I did these 60, and so I certainly have an experience in that and had a comfortability. So the only reason I say that is that everybody is going to have their own learning curve. I think my curve was a little bit easier in the beginning because I was already comfortable with the fact that I saw patients could do well with repair, so that made me feel more comfortable. My initial step was trying to find the right patients that I went in there and felt I was guilty about taking out the ACL. The quality tissue looked good. Could be some mild fibers, kind of like the videos I showed earlier that were kind of intact, and maybe the synovium's intact. And then it kind of evolved in more recreational athletes over 35. In Florida, we tend to have a lot of females over 40 that tear their ACL skiing with borrowed skis, where some college kid puts the bindings too tight and they come back down. It was interesting. I gave a talk in Park City, and they saw similar injury patterns amongst skiers. So I am a believer that different ACL injuries in different sports and different contact and non-contact can cause different patterns. Obviously, in skiing, it's the binding to boot interface, but it's not like a cleat into the ground and more of a violent tear effect. So I think that could affect quality of tissue at the tear site. And so I went through that scenario of, again, going in there. And then really the epiphany was, to me, was the conversation in the clinic and the idea to have the bare versus reconstruction. So I knew I could do whatever I needed to help the patient at the time of surgery. But my learning curve now is I tell every athlete about it. I've even had professional athletes that I've talked to about it. And that helps then guide the conversation. So now that I have the conversation, I have people that jump on it. Interestingly, when I get to the operating room, I think I've had one patient that has come back and said, you know what, I really want the reconstruction. Everybody that we give a brochure and they go to the website and they see the research that's been done on it. And I obviously talk to them a lot about that, not to what Dr. Murray talked about before, which I wish I could have her in a box in my clinic every single day, talking to those patients and showing them some of this information much more eloquently than I could. But I think when I've had that conversation, then patients have resonated, and immediately if you have a patient that wants to innovate, wants to know what's on the cutting edge of our field and how do we improve outcomes, and it's a great, I feel like I've had a great conversation point with patients in this regard.
Okay, I think this will be our last question. Another PT question for Dr. Osbahr. I'm a PT. Open chain knee extension exercises are thought to be safe early after reconstruction, 60 to 90 degrees at 2 to 4 weeks post-op. Is the same true of bare? Can we load these patients early given adherence to the range of motion restrictions?
I would say in the range of motion restrictions. I tend to not be a big open chain person initially, and I'm saying this very, very carefully because I am not a physical therapist. So that's my disclaimer here. So I would never want to go against it. I tend to be more of a leg press, mini squat, mini lunges, closed chain person initially. I just, obviously there's some physical therapists that are phenomenal, have a huge ACL history, and there's some that maybe haven't as much. And I get patients sometimes that you see are doing a lot of open chain work, start getting anterior knee soreness. And so obviously how you don't get quad lag, how you build the quad in the right way becomes a component, and it's an art, not a science. So I think as long as it's in the range of motion arc, it's probably safe, but monitoring for symptoms, and just my tendency is I don't tend to jump on the open chain stuff early. I try to stick with closed chain, but certainly always listen to my physical therapy colleagues because, if anybody is on here that I know, I respect you deeply and I appreciate you, and I need you to help me. I need you on that wall to help our patients.
Okay, I think, sorry, we have time for one more. This one for Dr. Osbahr as well. What percentage of the time when you have plans to perform a bare procedure do you choose intraoperatively to perform an ACL reconstruction?
It's definitely below 25%. But I would say when I'm in the clinic, I'm driving people. So when I convert from restoration to it, so most of the time I'm fairly confident based on the MRI that they're a good candidate. And then it's under 25% that I'm saying, you know what, the quality of tissue is not what I want it to be. But I think it has changed. Earlier on, it was probably 50-50. Then it went below 25. And I know it's below 25. Could it be 10 to 15%? Possibly, not positive. It's interesting. We have patients that come to the pre-op area now, and literally their comment is when we tell them, hey, we're going to try to do it, and then we're going to do a reconstruction. Most of the times, well, no, I thought you were going to do the restoration procedure. And so they almost are taken back again because they feel like, that's what they wanted to do, and as they've read about it. But again, my job, I tell them in the time of surgery is to make sure I put them in the best position possible and want to be thoughtful. The longest to go back to a question was asked earlier, the longest I've done one is probably 142 days. And it was exactly like Dr. Murray's mentioned, scar to the PCL. But the guy came to me because he heard he did it. And then he kept canceling surgery, and I kept telling him, I don't think I should do it. And then he's told me, basically, your success is going to be you doing this. And so I did it, and it scarred to the PCL, he had enough tissue. Now we'll see how he does long term, but that wouldn't have been a patient that I would have signed up and felt comfortable about. I definitely try to do them earlier. When I'm doing them, I tell patients, for me, the wheelhouse is between 2 to 4 weeks. Certainly after it gets beyond 6 to 8 weeks, then I say, hey, there could be some tissue issues at the time where I get concerned. But I do try to go earlier with these patients. But the wheelhouse for me has been 2 to 4 weeks to operate on them.
Okay. And I lied because there's one more really good question that came in. Dr. Osbahr, in your experience, are the results of Bair repair more lax than reconstruction?
Yeah, no, I would not say that. If I had a patient that I felt was more lax, then their opposite knee or more lax than I expected, that's when I'd get an MRI, especially after 6 months, giving it a little bit of time to consolidate. But I haven't been in the situation early on when I have felt that. I have not yet had a patient that has experienced that. But I know that patient's going to be there at some point. I think for all of us, when we go into the clinic, even reconstructions, if we're going to be very hypercritical of ourselves, I think we're not hypercritical enough of the outcomes from reconstruction. And so what I tell people, even with a reconstruction, sometimes it's tighter, sometimes a little looser, or it's about the same. And that's the way reconstruction's been for years when you compare to the opposite knee as we try to dial it in. So I haven't felt any difference in my experience over the last 2 years with this. But I know that patient at some point, like Dr. Murray mentioned, there's probably 1 to 2% that is going to happen. And I'm sure that patient is going to see me, and I'm going to get an MRI. And if the MRI shows concern, then I'm going to humbly talk about, hey, do we do a reconstruction at this point?
Okay. Well, that's the time we have for tonight. Thank you all for joining, and hope you enjoyed listening to Dr. Murray and Dr. Osbahr. Have a good evening.